Now, I don't know whether you can appreciate the difficulties that we have clinically, but we did talk about how not everything is in black and white. This is a slide that is supposed to be very busy, and that is the intent of it. In clinical practice, we see these are the major criteria, all the Ds that we talk about, right? The dementia, the delusional disorder, which is a psychotic disorder, the anxiety disorder, and then with the mood disorder, of which most of them would be unipolar depression. But you can easily see that some people who present with depression or depressive symptoms can overlap considerably with the other major disorders or symptoms that as geriatric psychiatrists we see. And therefore, sometimes in a given patient, at any given time, the diagnostic quandary is quite considerable. And certainly there is no law to say that you can only entitled to suffer from one psychiatric disorder. So there are comorbidities, and there are people who have a bit of this and everything, and who do not necessarily present in a very clear-cut DSM-4-like kind of a syndrome where you can easily then put them in a little pigeonhole called major depression or whatever depression. Now, I think we are all well trained in terms of understanding what major depression is. And in the specialist clinic that we run, we probably see a lot of patients referred to us because the primary care doctors couldn't manage. So we are familiar with treating major depression. You walk in the ward, you've got a patient with severe depression, with suicidal ideas, with psychotic symptoms, with severe psychomotor retardation. But in the literature, now it is suggested that actually major depression either remain plateau or in fact decline with, in old age. And most of the depression that the community samples present either to a primary care doctor or if you do a community survey will be the non-major depression. Now some terms that are being used include things like minor depression, in which the number of symptoms is less than 5, so between 2 to 5 or 2 to 4. There's not reached, that means it hasn't reached the diagnostic threshold for major depression. And then there's this term called subthreshold or subsyndromal depression that the literature talks about. So this group, which are highlighted in bold, would form the bulk of the depression symptomatology or syndrome that you will see if you are a general practitioner or you do a community survey. So I think this is familiar, I will not belabor on that. Now, when we talk about sub-threshold depression, certainly there are different definitions, but the fundamental thing is that first, it is the commonest type of depression, and it is clinically important because although they do not fulfill the criteria for major depression, some even sort of are less severe compared to even a major depression or dysthymia. What we know is that they are the commonest type, and also they have got a poor outcome compared to people who are not depressed. And their outcomes are not just in terms of the psychiatric symptoms also, but also with their functional status. In other words, although we call them minor depression or subthreshold depression, they have significant functional impairment. Sometimes some people say are even of the same severity as those of major depression. So in other words, we may not see them in our specialist clinic because we all run psychiatric services. But if you go down to the community, if you are the GP, you certainly will see them, and therefore they need clinical attention. It doesn't mean that they need medications necessarily, but certainly if you ignore them, they can actually cause significant morbidity for the sufferers. Now, one of the survey or reported literature is a paper by Beekman from Amsterdam that worldwide he sort of summarizes all the meta-analysis reported in different literature, and he sort of given this weighted mean prevalence for major depression to be just 1.5%, and whereas the depression of clinical significance, which is below the threshold of major depression, to be 13.5. So you can see the non-major depression is at least 10 times more than that of major depression in the elderly population worldwide. Now, why would major depression be less common? I mean, nobody really knows. I mean, this is just speculations, right? Some people believe that it is a cohort effect, right? And some people believe that it's just people, older adults, do not remember past history of a severe depression, or it could be because of the selection itself. Those who have severe depression die off through suicide, through whatever other non-suicidal causes, and those who left behind are those, therefore, who do not have major depression. And in a lot of survey and epidemiological studies, nursing home residents are excluded, and we all know that they have got a higher incidence and prevalence of major depression. Now, it is also a bit of a debate whether depression is more common in elderly or not. Some people say yes, some people say no. There are a lot of contradictory reports. Some people report a higher incidence of depression in old age, others did not. But the general rule is that if you take away, I'll show you afterwards, if you take away some of the medical problems and medical burdens, some studies have shown that actually older people do not have a high incidence of depression. So in other words, the depression is mediated through physical illness burden and the associated disability. But there are other changes in somatic and biological reasons, like the structural brain changes, the biochemical changes, social factors like bereavement, and institutionalization. These are factors perhaps may increase the risk of developing depression, and we talk about the risk factors just now. But what we know is that if you are depressed and if you're an older person, you have an increased risk of mortality versus those who are not depressed. Again, this is just prevalence. So community, elderly dwelling, these are the rates, 10 to 15%, of which the bulk of them would be non-major depression. But if you go to a hospital, if you go to a nursing home, the story would be very different. Or you go to a geriatric ward in CGH, for example. Now, factors that maintain depression in clinical samples. So we know that if your depressive episode index is longer, more severe, if you have cognitive impairment, if you have persistent poor health, and in social factors like if you are single, you live alone, you don't have a supportive social support like a neighbor, you are not attending club. This refers to social activity. In the context would be like maybe a day center or a community club. If you feel lonely, these are some of the factors that may maintain depression. In terms of etiological factors, we talk about different issues, early life as well as midlife factors that can contribute to the emergence of major depression. But sometimes these are the factors that will cause depression in earlier years. Now, when we talk about geriatric depression, we are talking about late onset primarily, but obviously people who develop depression in the early years of their life may then, if they don't kill themselves, if they take treatment, they may then grow old. So they will be what we call an early onset depression. But most of the time we're dealing with most of the slides that I'm going to share with you deals with particularly the late onset type of depression, where the onset of depression is in late life. Now, this just to sort of give you the comparators of depression in elderly, the early onset and late onset, and of course you have the young person with early onset depression. Now, you would notice that if you look at the early onset depression in an elderly, you find that a lot of the biologicals mirrors that of a young person with dementia. So again, it's not surprising. So you'd be looking at, for example, genetic factors playing a bigger role, and also neurotransmitter changes. But in terms of the psychosocial factors, they are more closer to the late onset type of depression, where you have all the psychosocial factors that increases the risk of developing depression. So it's quite intuitive, it's not rocket science, and therefore we know that in late onset depression, certain things like genetic loading and contribution would therefore be lesser than compared to the early onset varieties. Now, many risk factors, I'm just going to, because some of them has been articulated, I will be labeled